Boo, 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 boo. Oh, sorry. Just wanted to let you know what a personality disorder actually looks like. Of course, I'm kidding. It couldn't be me, could it? All right. Well, we're in chapter 10, if you haven't figured that out, with about personality disorders. Personality disorders are quite difficult sometimes to define for people because they're quite different from the Axis 1 diagnostic manual categorizations. These are they're included on Axis 2 in a diagnostic manual or diagnostic organization. And so I'm going to skip past this one and go to see if I can make my clicker work. There we go. I always have to hit that first. Okay, so personality disorders include 5 basic traits, which is openness is the first one. It's not in any particular order, but the first one I have listed here is openness, active imagination and sensitivity versus opposite of practicality and routineness. And then conscientiousness, self-disciplined and achievement-oriented versus less goal-oriented and more laid back. Extroversion, which is socially gregarious behavior. Gregarious is the word of the day. And the opposite is introversion. And then agreeableness, compassionate and cooperative versus suspiciousness and antagonism. And neuroticism, the tendency to express negative emotional states versus emotional stability. Some people exhibit extreme levels of personality traits but still function well because others tolerate their idiosyncrasies or their behavior does not significantly interfere with their job or marriage. High levels of certain personality traits can be adaptive. Other people, however, personality traits are extreme and they cause many problems. And they also usually have unusual, intense, and severe personality traits that appear in different situations. So it may not be that they show all the time. So let's just go through this. I like to think, here's one way to think about a personality trait versus, say, an Axis 1 diagnosis of depression or anxiety. Depression or anxiety is one mood. It's sort of like you can characterize it as one thing. You point to it. Yeah, it has multiple symptoms, but it's all the symptoms are kind of related to one tendency. And while there might be some differences such as irritability or sadness versus sadness in depression, they're still more alike than they are different. Personality trait can be thought of as if you took a clear jar of water or bottle of water, and you take a drop of ink and you look at that drop. It's black, right? And you drop that drop of ink into the water, and it diffuses throughout the whole volume of the water. And a personality trait is like that. It's a diffused type of behavior that sort of affects all areas of the person. So it taints how we react. It taints how we act in virtually all of the situations that we live in. It's sort of like it's how you're made, or it's how you've been. It's in the design. It's a design, perhaps a design flaw, but still, it might not be the design of the structure as much as could be the design of the environment the child was raised in. These personality characteristics or traits tend to be on a continuum. And you know what a continuum is. It's a long line where you have extremes on either end, and we're all somewhere in the middle. For instance, the personality traits we find in attachment disorder, there's very few people out clear on the end who are so extreme they might try to kill their parents or other people. There's more people that are sort of dishonest in the middle with themselves, or have little or no, or maybe very underdeveloped consciousness. Conscious as in that little voice inside that says what's right and wrong. So emotions you can have anywhere. You see here, this is one end of the continuum where you see them stable and low levels of impulsiveness, occasional thoughts as far as cognitions, occasional thoughts of spontaneity in socially adaptive ways. We usually call that creativity and thought process. And behaviors where you act different in different situations depending on the social context. So you don't, if you're in a meeting, a clinical meeting, you don't act the same as if you were at the going away party for your boss. You might be really happy about that. Or you might be sad because there's all kinds of emotions in going away parties. And then a mild, you can see occasional mood swings and impulsive urges. A lot of us are in the mild continuum. Occasional thoughts of spontaneous activities such as stealing. You might have thoughts of doing it, but you'd never do it. And acts inappropriately at times in work or social situations. So, well, maybe you would steal a few paper clips and not have a pang of consciousness, or you can ignore it because, I mean, they owe you that, you see. So that would be mild. And then moderate is frequent mood swings and some impulsive urges, but little impairment at work or relationships. So it's not getting in your way, but it's kind of it's there, right? Thoughts are frequently odd thoughts or thoughts of dangerous activities such as harming yourself or others. You know, those thoughts that I'd be better off dead, or not really that you're going to necessarily act on it. And then you might have problematic behaviors, personality traits such as impulsivity or emotional reactivity shown in many situations. So you're kind of come to be expected to be impulsive or kind of reactive. Maybe you get angry easy, you have a short fuse, all those kinds of things. And then severe or less severe, you can see, I'm not going to read all these, okay? You can see as these go up this continuum, they just get more intense and they become more problematic. In other words, they're causing you or other people problems. And when you look at some of these personality disorders in the mental health system, you can be labeled with some of these. And if you are labeled with them, that means they're pretty severe, because all of us have personality traits that are at times out of context or out of they don't fit with the situation. They cause us problems. But we, in general, 95%, 80 to 90% of the time, we're just acting like everybody else, which means that everybody has a little bit of this. You see, here's the more severe. And these are people that we tend to find in the system. So you look at the bottom there, problematic personality traits and dangerous behavior shown in all situations with intense distress and impairment. So sometimes they don't have distress so much as, well, they'll have distress, but they'll take it out on other people, or they'll take it out on themselves. They have thoughts of killing themselves or maybe hurting other people. And then these are why we have laws that if you know of a person having these kinds of thoughts or behaviors or emotions, we're supposed to report them to get some help. And in fact, it's in Oklahoma, it's the law for everyone. It's not just licensed professionals. The law states that anyone who knows of someone who's at risk of hurting themselves or others, or child abuse or elder abuse, we are required by law to report those things. And obviously, when you're a professional, that you would be held more accountable if you didn't, because you will have been trained by this time. You've already heard it multiple times, I hope, in these ideas. So you can have what's called a general personality disorder. That's just a category where, whenever they do that, it's where, this is causing the person a problem, but they might have symptoms of this and symptoms of that, and it's an enduring. That's what I mean by the drop of ink into the glass of water. It's enduring. You can't really. It's hard to filter out the drop of ink, right? It's just a part of the person, and it's enduring pattern. So you see this pattern of inner experience and behavior that deviates from the norm, from what other people would expect in the person's culture. And this is manifested by these two or more of the following. Cognition, just like we saw in our continuum, ways of perceiving and interpreting self, other people, and events. Affectivity. The affectivity is emotions. The range, intensity, lability means the amount of change of extremes in change. So it might be really low 1 minute and really excited or angry the next. Like somebody who has a short fuse would be labile, and we call that the lability, L-A-B, lability. And then appropriateness of or emotional response. So again, that would imply that the feeling levels are the inappropriateness of the response or behavior. Interpersonal functioning's been affected. They're not able to function in our culture to the degree that they can take care of themselves or others. And then impulse control, issues with impulse. So it could be any two of those. And the enduring pattern is inflexible. And this is the thing about it. Again, you can see it inflexible, enduring, flexible, inflexible, pervasive. Pervasive means it continues over a long period of time. It's not like you had a bad day. You have a bad day every day, pretty much, maybe more than 5 days a week you have a bad day. Or someone else around you has a bad day because of your behavior. And it's a broad range of personal and social situations. So again, you can imagine the drop of ink in the water. It's a broad range. It's affected every area of that H2O. Every cell, molecule of that H2O, not cell. And this pattern leads to clinically significant distress or impairment. The pattern's stable and of long duration. It just kind of repeats all those. So sometimes people, or when you're just getting to know a person, you won't, as a clinician, you may not have enough information yet, but they need, these categories, these labels. People need these if they actually have these problems, because that way they can get insurance to cover any issues that they have, or they have a better chance because they've got a diagnostic, they fit into a diagnostic label. You see, you got the problem with the medical system, if it is a problem, is that you have to have a problem for them to be able to pay for it, for the insurance companies to pay for it. So insurance companies won't pay for, as you've heard me say, marital therapy, because marital therapy isn't a disease. Ha, ha, ha. They should see some of the marriages that I know about. But it seems like it when you're in a marital relationship and it's not going well, it feels pretty bad. But it's not a disease. It's not considered a medically caused condition. So if you have a personality disorder, or if you had schizophrenia, you need that diagnosis. You really do, because that means you're going to get Medicaid funding. You're going to get the type of insurance that's going to be long and enduring, which is what you're going to need. And personality disorders are the same way. I worked at an eating disorder unit, and for the most part, the only people that were, it was an inpatient eating disorder unit, And for the most part, most of those folks either had they had eating disorder and a personality disorder. So they had a double whammy. Not only did they have an eating disorder, and it was hard to say which came first, but they also had a personality disorder that made it difficult for them to function and to learn, have relationships with other people. And so in order to have a relationship with a clinician so that they could get better, could get over their eating disorder, was very difficult because of their personality disorder. So they need the labels need to be given, not the label, but the actual description of the illness, the diagnostically identifiable illness needs to happen so that they can get the proper care that they deserve. Personality disorders are combined into or organized into three basic general categories. One is the odd and eccentric personality disorder. The second is dramatic, erratic, or emotional personality disorder. And the third is an anxious and fearful personality disorder. So, and those are listed underneath there, and we'll go through these rather quickly just so you get an idea. Paranoid. Paranoid is part of, remember, paranoid's part of the odd eccentric personality disorder group. And it's the person has a distrust, suspiciousness of others in their motives, or interpreted as malevolent. Malevolent is the second word for the day because it's hard to say. Malevolent means bad intent, beginning in early adulthood and present in a variety of contexts. That's another point that needs to be emphasized. Children are not given personality disorders. It's too difficult to tell if a child's just going through a developmental stage where you would swear they're acting like they have a personality disorder, but you can't determine at that point whether they're going to grow out of it, so to speak. So personality disorders in general are only given to adults. And you can read through each of these on your own. What happens, I'll give you an example of what happens if you're a clinician. Now, if you go to psychology school, in other words, you get a PhD in psychology, so you can do clinical psychology. Although my friend got a master's degree in psychology, and as long as you're working under another PhD, like in a mental health center, most states will allow you to function and get paid by the insurance. The insurance company will pay you for your services because they consider that to be, one reason is because there's not enough PhDs, and another reason is that there's not enough PhDs. So that's that, and plus a master's degree gives you enough information, and you're trained well enough to do counseling, especially if you consider that you can get a licensed professional counseling degree or a marriage and family therapy counseling degree and also get paid by insurance companies in most states. It depends on the state and it depends on the insurance company. And the only reason I dwell on the insurance part because that's the practical aspect of this, and it helps you understand why and how these diagnostic labels have come to be used and how they can be abused and or abused by not being used. If you don't give somebody the diagnostic, if they fit a category and you, to the best of your ability, have narrowed it down to that category, they deserve to have that label in order to get the care they need. I've pounded that into the ground, sorry. So you can read there's all the things about suspicion, doubts, unjustified doubts, lack of trust in others because of unwarranted fear. See, if the drug dealer's after me and has a big gun and says he wants to kill me, I may be paranoid, but that doesn't mean they're not out to get me. But if I've done a lot of, say, how somebody gets hopped up on methamphetamine for 4 or 5 days, which you can do, and not sleep and not eat, and you just keep doing the drug, after a while you start getting psychotic and you start having delusions. And a lot of times you're so paranoid, I've seen people call it stick to the window disease, because of course when you're doing illegal things, you're always scared the policemen are coming to get you. And maybe they are, but even if they're not, maybe if they don't know anything about you, you start believing that they are, and you'll start peeking out the windows and tweaking all those things that people do when they're messed up on drugs. So that would be an example of a drug-induced paranoia, which wouldn't be that would not be a personality disorder, but that's paranoia. So in this case, they don't do drugs and they still have this. And I had a guy in the prison system that had a paranoid personality disorder, and he was scared for me. He confided in me about his fears, and when he thought I was going to go tell the psychiatrist about this, he started getting it really enhanced his symptomology, because where he worked, he was working as a trustee, and he knew if he was put on medication for his personality disorder, if he needed it, that he would lose his level of being a trustee and he would be switched over to the general population, and he did not want that. And so basically I intervened and interceded for him to keep him from losing. I said, I don't think he needs medication. I think this is he was out on the milder end of the less severe, and it wasn't interfering with his work. It wasn't interfering with his daily activities. It was just that he had it. He had it all the time, and he was managing it on his own. And obviously you have to rule out other things such as schizophrenia, that kind of deal. Yes, they're suspicious. They can also, the odd or eccentric personality disorders include the paranoid, schizoid, and schizotypal personality disorders. The paranoid personality is a general distrust of others, and I basically have covered that. Schizoid is a pattern of detachment from social relationships. They're loners, and they have very restricted expression of emotion. So they appear to be very withdrawn. They don't make very many waves. They're very withdrawn back. Starts early in childhood or early in adulthood. They don't enjoy close relationships or being part of a family. They almost always choose solitary activities. Now, let me give you an example, and you can read through those symptoms. An example of this where it did not interfere with a person's, this would be an example that would not be interfere in the person's daily activities. Let's say this person that we're describing got a job with friends, help of friends. He got a job at the movie theater, and he ran I don't even know if they have movie cameras up there, movie projectors anymore. I think it's all digital, but they must have someone who turns it on and shuts it off. But let's say he got a job up there. He didn't have to interact with anybody but one person, and that person understood that he had, maybe the mental health center helped him get this job, and that the employer understood that he had this problem with relationships, and so he limited his interaction with him, and just so he did a good job, that's all that really mattered. And the guy came to work, did his job, goes home, does what he does at home. Maybe he plays video games, or maybe watches movies, maybe he reads books, maybe we don't really even know what he does at home because nobody's there to see it. So, but he's not a danger to himself or others. So there's no reason to bother him. you can still, if he ends up at the mental health center, which is probably not likely, because as long as he's not causing a problem, he's not going to come around a mental health center to get a diagnosis. So for the most part, you're not going to see people with these personality disorders unless they somehow get, in trouble in the system, and then you would have somebody have them show up. They just want to be left alone. Schizotypal personality disorder is more complex and more difficult. Probably would take more time to diagnose, and you'll see why. It's a pattern of social interpersonal deficits that is marked by acute discomfort with and reduced capacity for close relationships, as well as cognitive or perceptual distortions and eccentric intrasticities of behavior. And it starts early in adulthood, and it's present for a variety of contexts. So you have ideas of reference, which is delusions of reference. So thinking that people might be making up things about you that aren't true, ideas that someone coming from somebody else that you're sort of implying, you're inferring that's happening. Could be paranoia, odd beliefs or magical thinking that influences behavior and not normal in the culture. Unusual perceptual experiences, including bodily illusions, so feelings, sense of body floating, sense of just odd things that you would normally feel. Odd thinking in speech, suspiciousness or paranoid ideation, appropriate or constricted affect, behavior or appearance that's odd, eccentric, or peculiar. Now, when you look at this, behavior or appearance that's odd, lack of close friends or confidants. So why would this be difficult, do you think? Just wait. I'm just throwing this question out there for you to think about. Why would this be difficult to diagnose? They're all difficult to diagnose because you have to get to know the person long enough, or get to know their relatives long enough, or they're people, in order to find out about them clearly. Well, what would you think? Well, let me give you a couple of reasons. One reason is because people with this type of disorder, if you get around them, if you happen to run into them in the system, which is not likely, because they don't want to be around people particularly either, which makes them a lot like schizoid. But you can see the differences in their odd thinking, their eccentricities of behavior, and also their behaviors. When you describe these symptoms, they're pretty close to sounding like a paranoid schizophrenic, right? So you have to differentiate between the schizophrenia and schizotypal. Schizotypal, remember, is enduring. Well, so is schizophrenia. So scratch that. Well, it's an enduring personality trait, though. They're personality traits. They're not like they're having hallucinations all the time, or whether that's listening to voices. They might have occasional voice or have those as odd perceptual disturbances. It might be more like they think that they are special and that they have special information that we all need, as you'll see in the next slide. But you have to differentiate between that and, say, a bipolar personality or a bipolar disorder, where they're bipolar and they have odd moods, as well as you can have psychotic traits in the manic stage of a bipolar disorder. You can have psychotic states in schizophrenia. You can have psychotic states in depression. So it takes enough time to actually diagnose personality disorders and to differentiate them from the other behavior or other personality, other mental illnesses. This character is somebody I'll probably have well, I actually do have a video that I'll have you guys watch now. I think we're on we're only at 10. Okay, I'll probably just post the video below the PowerPoint so you can watch this after. But he's quite a deal, a guy. I'm not getting his name right now, but you'll get it in the video. And he's a character that he believed that he was getting messages from outer space, and he started a cult, and they drank the Kool-Aid. They didn't. It's not the one that went to Guyana. This is one here, right here. I believe it was in Europe, maybe, where they actually ended up. But anyway, they literally did drink the Kool-Aid, believing that it was laced with some kind of poison that was lethal. And they were found laying on their beds in the communal situation that they were living in, where they drank their poison, and they believed that they would leave their bodies and go join the aliens who were waiting for them in the spaceship. So it can sound a lot like, but see, a schizophrenic would have a hard time organizing people into a cult. And this guy had a personality disorder which did not interfere with him influencing lots and lots of people to commit suicide, to literally commit suicide. Personality disorders, these personality disorders occur in about 4 to 15% of the general population. So you can see that personality disorders are that's pretty high, but it's still not, 15% is high. Odd or eccentric personality disorders occur in 2.1% of the population. Excuse me, I was reading that wrong. Personality disorders in general occur in about 4 to 15%, but the odd or eccentrics are 2.1%. Racial and ethnic differences are not prominent in personality disorders, probably because we really don't have enough information. It's not reported well enough. We don't really know how many people have it because there's a number of people who are functioning properly, and so they don't end up being noticed. You may have watched No Country for Old Men, and he exhibited the next type of personality disorder, which is dramatic personality, psychopathology, which is a lack of feeling for other people. Antisocial personality disorder, that would be our friend back here. He definitely had an antisocial personality disorder. These are people who have a pervasive pattern of disregard for and violation of the rights of others occurring since the age of 15. You notice they actually drop the age on these characters, literally characters, personalities, characters. Because, and what happens, this one usually it comes out of a diagnosis of conduct disorder in childhood. So that doesn't mean that everybody that gets a diagnosis of conduct disorder in childhood will go on to have an antisocial personality disorder. But conduct disorder is, if you remember us talking about this before, you can have oppositional defiant disorder as a child, and then you can have conduct disorder. And the difference between the two in general is that conduct disorder is where you steal or hurt another human being. Oppositional defiant disorder is simply just being oppositional. But conduct disorder is going over another line there where you're actually violating the rights of others. But we won't give them a personality disorder until the age of, at least the age of 15. They don't conform to social norms. They're deceitful, manipulative, impulsivity, and failure to plan ahead. They just live for the moment. They just live to make themselves feel happy. Irritability, they don't really care if it makes you feel happy. They can be irritable if you get in their way. Aggressive, especially if you get in their way, they can be very aggressive. Reckless disregard for safety of others. Consistent irresponsibility, repeated failure to sustain consistent work or behavior or honor of financial obligations, and lack of remorse. So when you read in the attachment disorder book about the lack of conscientiousness, that's what you're probably seeing the beginnings, if they're not given pretty intensive treatment, the beginnings of these types of personalities or other types of personalities, or like avoidant attachment disorder could go on to lead to becoming schizotypal or schizoid. And the problem with that is I don't know that for sure, but it's just my hunch, is that if it's caused by childhood experiences, environments, I think you're looking at attachment disorders of some type. And Dr. Randolph talks about that in her book as well. So here's a list. It's basically the same thing we went over. Borderline personality disorder, this is the one that you'll hear most about in the mental health system. Going back to antisocial, these are the folks that you'll find they'll most likely be locked up in prison if they're on the extreme end, because people don't want to have people violating their rights, and they have a reckless disregard, and they don't think ahead or plan ahead. They don't think about that this behavior is going to get me landed in jail. They believe they're going to get away with it because they're so smart and so cunning, and they do sometimes for long periods of time, which is where you see a lot of serial killers and that kind of thing. They're very manipulative. They're very good at what they do, and that's how that works. Borderline is, you hear about these people in the mental health system because they're not appreciated in the mental health system by most clinicians, because they are extremely difficult to work with in most cases. And you see why in a minute. A pervasive pattern of instability of interpersonal relationships, self-image and affects, and impulsivity. And the problem with this, of course, is that to be in a therapeutic relationship, or in a relationship with a case manager or a therapist, you have to, it involves having a relationship with that therapist. And the very fact that their personalities get in the way of their relationships, because they act out, on one day they will see you as a knight in shining armor, or a princess, or their savior, and an hour later, or they will get an idea in their head that you have betrayed them and you will be the worst slime on earth, and they will sometimes take it out on you. They have interesting ways of interacting. One woman that I worked with in the mental health center became very friendly with me in terms of, not in the sexual sense, as far as I know, but she found out, and I'm very, as a therapist, I tend to use self-disclosure. So just in visiting with her, she was very good at getting you to talk about yourself. And once she found out I had children, she started leaving me small gifts for my children at Christmas time in my car that was behind the mental health center and was unlocked. She baked cinnamon rolls and left them at my father's, because it was a very small town where this mental health center was. And she figured out where my father lived. I mean, everybody knew everybody there. She had moved to town, and she figured out where my father lived. She left him cinnamon rolls on the porch of his house. She also, there was a church that decided they were going to help her, and a group of don't ask me why these men were so ignorant, but they met with her at her house, even as a group, met her, and she started implying that they were becoming sexual toward her. So you can see how this she would not gain much popularity around the mental health center, because that's going to cause you problems. They have a lot of tendencies to have suicide attempts. Self-harm is very common with these folks. They can just swing down, and they make, it's not bipolar, because it's almost an impulsive kind of swing into, and it's also a lot of times they're suicidal gestures, which they might be, they might accidentally complete, but in general, they're not trying to complete it. They do it for a way to get your attention. They're so starved at certain points for attention, they'll do anything to get people to pay attention to them because they feel so desperate. Histrionic is a pervasive pattern of excessive emotionality and attention seeking beginning by the early adulthood and presented in a variety of contexts. So these are people, histrionic you might think of as the dramatic personality disorder. They tend to be very dramatic, they over-dramatize situations, they feel uncomfortable when they're not the center of attention. In other words, you can think of a vain actor who thinks that they're such a great actor, and they have a very large, puffed up personality. Their interaction with others often characterized by inappropriate sex or seductive, provocative behavior, rapidly shifting, shallow expression of emotions, constantly uses physical appearance to draw attention. So they love to dress flamboyantly, or maybe the opposite way as I can't think of the word. The people, you can holler at the computer, but people that walk around in black clothing, I'll think of it in a minute. You know what I mean. Kids at school do that. They consistently use physical appearance to draw attention. Okay, a style of speech that is excessively impressionistic and lacking of detail. So self-dramatization, theatricality, exaggerated expression of emotion. They're very suggestible, and they consider relationships to be more intimate than they actually are. So they really come across, and you can see how this could be mixed up with borderline, and quite often you'll have somebody will mark on an axis 1, they may have depression. On axis 2, they may have personality disorder with histrionic and borderline traits. So, sometimes we're just trying to get enough information that people can understand what they're working with. Narcissistic personality disorder. These are folks that are they appear extremely self-conscious, self-confident, overconfident. They're grandiose. They're bigger than life. They have a fantasy in their behavior that they are just so wonderful, and they may not say it, but they feel it. They believe themselves to be just the most fantastic human being, or their behavior might show it. They have a need for admiration, and they have a lack of empathy for others, and so they have a variety indicated in the variety of contexts, which they also have a grandiose sense of self-importance. It's preoccupied with fantasies of unlimited success, power, brilliance, beauty, believes that he or she is special, unique, and can only be understood by, should be associated with other special, high-status people. And again, you'll see personality disorder with narcissistic or personality or histrionic traits, or narcissistic and borderline traits. you'll see a mix of traits with these folks that makes it really hard to narrow it down. It doesn't really matter as long as you actually are able to identify the symptoms. They have a sense of entitlement, which also people with antisocial personality have essential entitlement. So these are get all mixed up. They're very interpersonally exploitable. So if you understand them, what their need is, you can lead them on. You can make them believe that you believe in them, and that and they'll do anything for that. They can also be arrogant, haughty, and have haughty behaviors or attitudes, and they're very envious of other people. So people, the thing to remember about them is that they're also extremely vulnerable. So if you can ever get to the point where they kind of live in this blow up doll personhood. So they blow this doll up as, this is who I am. Aren't I wonderful? It's all a mask. It's all a sham. Because deep down inside, they just feel like the little shriveled blow up doll would be all shriveled if you take the air out of it. And if you ever pop their bubble, so to speak, that they live underneath, you find that they're extremely vulnerable and can become extremely suicidal. So I had run-ins with people in the system where they may have had incest with their son or daughter, and they believe that they have believed so long that only if only their wife would understand them the way their daughter is understanding them, then life would be much better. And the daughter is just a child. And what happens is then they begin to use that child for their emotional needs, and pretty soon that leads to physical needs. And I know, that probably makes you sick. But I'm just giving you an example of how this can lead a person to do some really terrible things. And believe it or not, people who commit that style of incest, that style of sex abuse, can and do receive treatment. The family can and does receive treatment that can be very effective. Now, that may sound out there, but it really does. It's people can get treatment for these things, and actually, although personality disorders are very difficult to change, it doesn't mean that the person can't become aware of their disorder, just like you or I could become aware that we have schizophrenia, and that we need to do something different in order, or I could become aware that I have antisocial personality tendencies, and I can learn that if I don't learn to think ahead, I'm going to end up in prison. And I don't want to end up in prison. I want to be out in the world doing what I want to do, see? And so I could also learn to be just more manipulative and avoid prison. Or I could maybe learn a different way. Maybe I could learn to act as if I have a conscience, because that's what people with consciences act like. And I want to act like I want to fit in someday. Maybe I do have a hope or a dream that I want to fulfill. Okay. I think I did that. Here's an example of a histrionic personality. A person with histrionic personality is where you can see the flamboyant dress, discomfort with situations where they're not the center of attention. So, and again, they're very similar to narcissistic, very low self-esteem, they'll act as if they have a lot of confidence in these roles, but if you ever poke that bubble, they're very, very vulnerable and very in danger of hurting themselves. So I'm just going through these a little quicker because this has been 50 minutes. It seems like a long time for me to talk, huh? The dramatic personality disorders are about 5.5% of the general population. You can read this in your book. There's a box. Avoidant personality disorder. These are people that have a pervasive pattern of social inhibition, feelings of inadequacy, hypersensitivity to negative evaluation, beginning by early childhood and present in a variety of contexts, as indicated by 4 or more of the following. Avoids occupational activities that involve significant interpersonal contact because of fears of criticism, disapproval, or rejection. So this is specifically avoiding kinds of relationships that you have to differentiate between some of the others. For instance, Schizoid. It's unwilling to get involved with people unless certain of being liked. Shows restraint within intimate relationships, just out of fear of being shamed or ridiculed. So they're very protective, very avoidant of any chance. It's not avoidant of people so much as avoidant of being rejected. And inhibition to have new interpersonal situations. So you can see that's clear. Dependent personality disorder. So you can imagine what this is like. Having difficulty making everyday decisions without an excessive amount of advice and reassurance from others. Needs others to assume responsibility for most major areas of his or her life. Has difficulty expressing disagreement with others because of fear of loss of support or approval. And difficulty initiating projects or doing things on his or her own because of the lack of self-confidence or in judgment of abilities. Goes to excessive lengths to obtain nurturance and support, and feels uncomfortable or helpless when alone because of exaggerated fears of being unable to care for himself or herself. So this would be codependency to the max. Codependency is not a diagnostic category unless you would consider dependent personality disorder. And I think there's a difference. I think codependency tends to be something that a pattern of behaviors that you've learned, whereas dependent personality disorder is more how you're put together and more difficult to change. So there it is. Obsessive-Compulsive Personality Disorder. Well, if any of these others were confusing, this is probably the most confusing. But what you have to read in this one compared to OCD is that it's a pervasive pattern of preoccupation with orderliness, perfectionism, and mental interpersonal control at the expense of flexibility, openness, and efficiency. So it's not about cleaning, going back and cleaning doorknobs 15 times or checking the locks 15 times. It's about needing perfectionism, having a preoccupation to make sure everything's in order, that everything's in a perfect, and everything's under control. It's a real control issue in the personality. So it's about who you are. It isn't about, it's just how you're put together. It's in your, again, it's the drop of ink into that glass of water. And you could think of the drops of ink as being different colors and different types of personality disorder. So you can have one type that's red, one type that's blue, just for a model. I mean, just to help you think about these things. You can't really identify it as like an OCD It's kind of like a thing they identify about themselves, whereas this is who they are. And so it's just the way it is. It's not like a disorder to them. It isn't a problem so much of, say, cleaning, making sure a lock is locked, and that I believe over and over again that it's not. It's about everything needs to be in order. Everything on my desk has to be in a certain spot. You've probably seen movies about that. You would say people like that have these type of tendencies. So I'll let you read through those. I'm not going to read through every one of these, but this one, it gets mixed up with OCD, obsessive-compulsive disorder, versus obsessive-compulsive personality disorder. Just remember that the difference is it's a pattern or preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency. So it's across the board, too. It's not just in one specific area. There's about 2.3% of the general population have that anxious, fearful personality disorders. There's a lot of stigma associated with these things because it actually people assume that they caused the problem, that they just need to straighten up, they just need to quit acting like that, quit dressing like that, quit, don't get so emotional, don't, whatever it is, however it's manifested. Mental health professionals do not like people with personality disorders because they believe they're incurable, which is not true, but it's very difficult to change. I'll give you that. Many patients are misdiagnosed and receive ineffective psychological treatment or medication. So medications don't tend to be very effective. Yes, if you are depressed and you have a personality disorder, we can give you treatment for your depression that might include antidepressants, but it's not going to affect the personality disorder. Is still going to be there. There's no pill for it. Related to genetics, the emotional expression, suspiciousness can be related. You can have a predisposition to being suspicious, and you can also have a predisposition to cognitive distortion. In other words, you can inherit a tendency toward that, and if you grew up in a family where that was being expressed a lot, you're probably going to have it triggered and expressed in yourself as well. Not that they're causing it, but that they are actually playing into it and helping it to manifest itself from your genetic makeup. These are just environmental risk factors. This shows you causes of the odd or eccentric, and it gives you different causes there: biological vulnerabilities, genetics, early family problems, adverse family environmental, stressful events. So basically, how you have interacted with your family. It shows you some brain function. I'm not going to make you guys necessarily spend a lot of time on that. Environmental factors for dramatic personality disorders include childhood maltreatment, poor parental bonding, and cognitive beliefs. So here's where you see your attachment disorder manifested in adults. I'll let you read through that, each of these. I'm going to get through this so we can be done with it. So it shows you where we really don't know, but the environmental risk factors may be related to these types of treatments as children. And attachment, see there, insecure attachment to parents, abuse, neglect, And that shows you some of the other ideas for this as you can look at. You can pause this and look at these longer if you want to. So preventing child abuse is probably going to improve attachment, or not attachment, well, it's going to improve attachment disorder as well, but on adult, when they become adults, personality disorders. This is the way they test for it. We use unstructured clinical interviews, self-report questionnaires, structured clinical interviews, and informant reports. We listen to other people about the person's behavior. Some do respond to medications if they have cognitive perceptual problems or affect, emotional problems, and impulsive aggression can be, there is medication that can help with those. Group therapy is very helpful. Having people learn to have relationships in groups, in the group itself, gives them practice so that they're not ostracized for their behavior in the larger world. We can work with people in the group in psychodrama and those kinds of things that help them to practice new skills, new ways of interacting with people. That's just examples of questions from personality disorders. We tailor treatments, like, for instance, behavioral treatments, cognitive behavioral treatments, and also dialectical behavior. Therapy is a combination of meditation, group therapy, individual therapy, and skills training. So it's kind of a day treatment program where the person would go during the day and take classes to change their behavior. So these are chapter reflections. I would just include you to ask you to reflect on those in the reflections of after you go through these PowerPoint slides. Thank you for your attention today, and I'm sorry it took an hour. Hope you guys learn to pause this and take it a half hour at a time, because it's going to be difficult to sit for an hour, I know, and pay attention. So, but it's done now. You can go back, or you could just pause it in the middle and come back. All right. Thank you for being here. Thank you for being in my class, and I hope you're learning a lot.